Hello, my name is Karina Cabrita and I'm a product manager at Cytognos. Thank you all for attending this webinar. It is my pleasure to introduce to you our invited speaker, Maria Arroz. She will present to you this webinar titled Why Changing from Manual to an Automated Analysis of the LST Tube. Maria Arroz is a medical doctor and a clinical pathologist. Currently, she is the director of the flow cytometry laboratory of the Centro Hospitalar de Lisboa Ocidental, located in the Hospital São Francisco Xavier in Lisbon, Portugal. Her laboratory is a reference center for flow cytometry clinical applications and a teaching facility for new users in this field in Portugal. Their research is mainly focused on the immunology of HIV infection, leukemia and lymphoma diagnosis, and minimal residual disease in multiple myeloma. Maria has been a remarkable member of several flow cytometry societies and committees, such as the ICCS Quality and Standards Committee, CCEN Course Committee, Clinical Cytometry Society Council, among others. She has also been Vice President of the bi-variate Cytometry Society, Board Member of the ESCA, Director of the ESCA Clinical Cytometry Courses, President of the 14th ESCA Conference, and Board Member and Associate Editor of Cytometry. Maria has delivered over 70 lectures at courses and conferences in 18 different countries around the world. She has authored or co-authored number research contributions. Welcome, Maria, and thank you for being here today.
Thank you for this kind introduction. I'm here welcoming you all to this webinar about why changing from manual to automated analysis of the LST tube. I will start by describing the construction and validation of the LST database for automated identification of peripheral blood lymphocyte subsets. I will then address 4 examples of peripheral blood T and B cell chronic lymphoproliferative disorder cases, followed by live analysis of an hairy cell leukemia case, and I will wrap up with questions and answers. To construct the reference LST database, data files corresponding to 119 LC donor reactive samples stained with the EuroFlow LST antibody panel were used. This tube, as you are probably all familiar with, has 12 monoclonal antibodies which are conjugated to 8 different fluorochromes. And as such, we have in different fluorochromes more than one antibody, in fact 2 antibodies, as is the case of 20 plus CD4, lambda plus CD8, kappa plus CD56, and CD19 plus TCR gamma delta. Here in this table you can see how the major populations, both lymphoid and myeloid populations, were identified using this panel, and I would just like to call your attention to this designation and specified nucleated cells that are in fact the basophils and dendritic cells that are not identified as isolated populations. For all the details regarding this first part, I would like to call your attention to this paper which was published in Journal of Immunological Methods by the EuroFlow groups. 4 different centers, 5 different centers are represented and made this evaluation of the LST database. Well, they picked up 2 experts which performed an analysis of these data files, and these 2 experts had the following Boolean gate strategy. Well, they started with the T cells, CD3 positive T cells, and then they looked at the CD4 positive T cells and the CD8 positive T cells, the gamma delta T cells, and the double negative non-gamma delta T cells. The B cells were identified based on their expression of CD19 and being negative for CD3, and also positive for CD20. Most of them, as you can see, are CD5 negative, although a few may express CD5, a few normal B cells may express CD5. Looking into the light chain expression, then they identified the kappa light chains and the gamma light chains. Moving to the NK cells, they had to be, of course, CD3 and CD19 and gamma delta negative. They would express 56. They had to be located within the lymphoid gate on the 45 site scatter, not expressing CD20 or CD4, expression of CD8 and also of CD38. Eosinophils were only identified based on the 45 site scatter and the fact they were negative for all the other markers in the tube, even though they express some autofluorescence, which at some dot plots may seem like diagonal. They are located on the diagonal. The monocytes were 38 positive, dim expression of CD4. They were located between the lymphoid and the neutrophil populations. They were negative for 19 and gamma delta and 5 and 3. And the neutrophils had intermediate expression of CD45 and side scatter and were all negative for all the other markers. In each of these analyses, I call your attention to the fact that both debris and doublets were excluded so that populations might be purified. Plasma cells were identified on the basis of high expression of CD38, expression of 19, and some of them might express CD20 as well. They were negative for CD3, and they had a slightly higher side scatter when compared to the normal B cells. And finally, the unspecified nucleated cells, as you can see, are represented by both the basophils and the dendritic cells, and they are located at CD45 side scatter here, and not individualized as specific populations. So the technical quality of each data file was evaluated, and they ended up with only 46 data files which were merged in the reference LST database. Different cell populations are color-coded and represented both as colored events and as larger colored circles for all parameters displayed in the peripheral classical or conventional dot plots. And in the center you can see the clustering, the canonical clustering analysis, which is only represented by the larger circles. Every single one is, of course, one population, as it represents the color of the population. It's one population, and in each of the 46 databases. So, to conclude this part of my talk, I would like to say that the LST reference database for peripheral blood samples was designed, constructed and validated for automated gating of the distinct lymphoid and myeloid subsets in peripheral blood of patients with CLPD. First, the clustering step that identifies groups of events with similar characteristics in the multi-dimensional space generated by all the parameters evaluated. Then, a classification step in which all individuals clusters of events obtained per data file are compared with each predefined cell population in the reference LST database for both their phenotypic profile. And for this they use two different algorithms, the principal component analysis and the canonical clustering analysis, and relative distribution according to age. To construct the reference values for age, 187 peripheral blood samples were used, and they were divided into four different groups. Less than 15 years old, between 15 and 30 years old, from 31 years old to 50 years old, and more than 50 years old. And this database was validated with 92 samples of 10 LC subjects, 51 B-cell CLPD and 31 T and NK cell CLPD patients. A median percentage of alarmed cellular events of 0.8% in LC donor samples and 44.4% in CLPD data files. So it is completely different to have a normal sample as compared to a sample that has tumor cells in it. The higher percentage of alarmed cellular events in every CLPD was due to aberrant phenotypes and or to abnormally increased cell counts. The latter was more relevant in the T and NK cell CLPD cases, which means that in these cases there were less abnormalities in the immunophenotypic profile when compared to the B cell cases. And the comparison between automated versus expert-based manual classification of normal and tumor cell populations showed a high degree of correlation. So based on all these things, which strategy of analysis should you choose? You can choose between the current expert-based conventional strategies, which are strongly dependent on individual expertise and prone to subjectivity, or you can now choose the automation of cell identification, which is a robust and reproducible gating and labeling, and is standardized and simplifies the analysis. But you should not be afraid that your input is not needed, because whenever there are cluster of events that show differences, they are automatically alarmed as populations to be checked, and to be checked by you, by an expert. So let's now move on to the cases. We have the first case. So after the automated analysis, what we can see is that all the populations are assigned when compared to the database, all the normal populations. And then there is a message that you should fill in the absolute number of leukocytes. And this again is very important because of the reference values, which may be one of the alarms that the software generates. After performing this, you should move to check the populations, and you can see there are several different populations, and you see the plus sign. Whenever you see a plus sign, you should click on it, and it will open subpopulations like branches of this hierarchical tree that need to be checked. And usually they recommend we should start by the bottom population. So I will give you a couple of examples. For instance, in this case, the black dots, which are the dots we need to check and assign, the black dots are within the CD8 positive, CD4 negative population. But as you can see, they are CD8 positive, but they also express CD4. And if you look at this dot plot, you can see that they equally co-express CD4 and CD8, and so we should assign them to the double positive population, the turquoise population. Another example regarding, for instance, neutrophils, we can see that the black dots we have here are, some of them are debris and some of them are doublets. And in fact, what the software does, it gives us suggestions with more probable population, and as you can see, one of the suggestions was the debris and the other was doublet, so it was correct. We just have to assign them into the correct population, and then we move on. And when we finished, there comes this pop-up window in this case, because it's a pathological sample, and it says that there are populations above 20% of the reference, and it is necessary to review them. And the populations that we need to check are the CD4 positive T cells, and it displays all the CD4 positive T cells. Here you can see there is the turquoise dot plots, which were the double positive, and so we have three different clusters. This dot plot, EAPS, this graphic, this plot, in fact, as you can see, it has no labels in the axis, and this is because it takes into account all the fluorescent parameters and the scatter parameters, and they group the dots into clusters of cells. And this is really very helpful in some cases in our routine analysis. And you can easily see there are three different clusters. And these three different clusters represent, one of them represents the normal CD4 positive T cells, the one in here, but two of them express CD56. And CD56 expression is not usual for the CD4 T cells, because CD56 is associated with effector cells in the maturation. Here, because we have two distinct populations, one of it corresponds to the CD4 positive, CD8 negative T cells, and the other one corresponds to the CD4 positive, CD8 positive DIM. So I've decided to assign them both as in red, which mean the abnormal expanded cells, and when this analysis is complete, the software displays all the dot plots, and every single dot must be colored and distributed to different populations and subpopulations. And in the bottom you can see exactly that. You have the leukocyte subsets, starting with the eosinophils, neutrophils, monocytes, and lymphoid cells. Then you can see that red dots are inside the T cells, but here nothing wrong is with the B cells. And here you can see that not only they are T cells, but also they are CD4 positive T cells, where these red dots are contained. And now we can move to the report. And the report gives us two different aspects. First, it gives us the normal populations in the sample, and this is important because we are not only focused in identifying the abnormal populations, but we take into account all the normal cells inside the sample. And these are displayed here, both their frequency and absolute numbers, and you have the reference values so that it can compare to the reference value according to age, see, more than 50 years old. And whenever these numbers, this phenotype is displayed in bold, And the numbers, it means that it deviates from the reference. It may be higher, as is this case, or it may be lower, as is this case. Or this case, about neutrophils, because we had an expanded T cell population. And here we have the description of the expanded T cell populations. At this point, I decided to separate them and then see if they are the same clone or different clones. But of course, I can only say that after I've done the clonality studies. Well, next we can see the immunophenotypic description of these abnormal expanded cells, and as you can see here, they have a higher site scatter. They are CD4 positive, CD8 negative, CD5 positive, 3 positive, and no expression of 38. And as the conclusion, they would say that the clonality studies, characterization and classification of these cells are required. And that's what we did next. So I'm showing you the study of the TCR V beta families that we performed, and we use a kit which has 8 different tubes. In each tube we have 3 different V beta families. So in a total 24, which represent around 70% of all the V beta families. And the way this this kit is organized is that in every tube we have, as I told you, 3 different families. One, in this case V beta 14, is conjugated with FITC. Another one, in this case V beta 11, is conjugated with PE. And the third one, in this case V beta 22, is conjugated with both FITC and PE, and it is represented in the diagonal of the dot plot. So these green cells are the cells that are all V beta 22 family. All the other families are almost not represented. The sample is represented with the blue, in blue, and the rest are the median values of the reference of this kit. And when we look at these green cells, and let's check, because we can use also, we only occupy 3 positions, 2 positions in fact, of monoclonal antibodies, and we have a lot more positions empty, so you can fill like CD3, CD4, CD8, CD45, and in this case we can confirm that the 2 clusters we previously identified in the LST automated tube analysis were both belonging to the same V beta 22 family, not only the 4 positive 8 negative clone, but also the 4 positive 8 positive DIM clone. So both clones were in the same family, the same clone, and this was the same disease. If we now look at the immunophenotype, as I'm just bringing 2 examples, these CD4 positive abnormal cells do not express CD28 or CD26, which are co-stimulatory molecules, but they in fact they express cytoplasmic perforin, which is present in cytotoxic cells. And here you can see our internal control in the tube, because the normal CD4 cells do not express perforin. The CD8 cells, some of them express perforin, the cytotoxic ones, and the non-effector cells are perforin negative. And in the background, you can see also the NK cells, which of course are cytotoxic cells as well, most of them, and have perforin expression. Now, coming to the second case, I'm going to show you the normal B cells, the kappa and lambda normal B cells, and then to check the alarms told us to verify another clone, another group of cells, another cluster of cells, and this cluster expressed CD5, had heterogeneous expression of CD20, and they were small cells. And when we look at light chain expression, we can see there's a dim expression of kappa, or sometimes we may even not be sure whether the cells expressed membrane light chains. In this case, we shall see what the software, the report, will tell us about these cells. So this is the final dot plots, all the final dot plots, and you can see this is a BCLL, as we was suspecting, based on the profile which I previously described. And here is the profile. So we have a normal forward and side scatter. We have low expression of CD20. We have CD5 expression, CD19 expression, and no expression of CD38. And it tells us that it is surface Ig kappa restricted. And he does this based on mean fluorescent intensity values when compared to the reference database. The third case is another T cell case. So we have here displayed the subpopulations of the T cells, the double negatives, we have the gamma delta positive cells, we have the auxiliary T cells, cytotoxic T cells, and then there's a cluster of cells which are CD8 positive, and when we look at the expression of the CD5, we clearly see it's different from the rest of the normal T cells. So it's from positive to negative, a very heterogeneous expression of CD5. And when we look at the APS, we can clearly see that this cluster clearly separates from the rest of the clusters. And this was a case of CD8 positive T cell large granular lymphocyte leukemia, which is the counterpart of the first case that was a CD4 positive T cell LGL leukemia. And if we move to the report, it will tell us that they have a low site scatter, they are 4 negative, 8 positive, and only 18.9% express CD5, and they have a very small expression of CD38. And again, whenever there is a clonal expansion of T cells, it will indicate that we should move to clonality studies, and as a first step, as EuroFlow recommends, and then in case we find clonality, we should go to characterization and classification of these cells. Case number 4, we start with the normal B cells. As we can see here, the kappa and lambda normal B cells, and then we move to the alarm. We check the alarm in the B cells. We have a cluster which is represented in red, and these cells have similar CD19 and 20 expression. They do not express CD5. They have a dimmer lambda expression, and they are slightly bigger size than the normal B cells. and they only represent 3.4% of the whole cellularity. But we had also to check the T cells. Here we have our normal T cell distribution, and then we have a cluster of CD4 positive T cells. These CD4 positive T cells, unlike the first case, do not express CD56. They have a slightly dimmer CD5 expression, and they have a kind of heterogeneous expression for CD3 and a slightly dimmer expression of CD4 when compared to the normal CD4 T cells. So this sample represents two different tumor cells, one T non-Hodgkin lymphoma and one B non-Hodgkin lymphoma. And as you can see in the bottom graphics, you see there's both a B and a T expanded clone. Here the B and here the T, and of course the T is bigger. It's bigger, it's 19.5 when compared to 3.4% of this the whole cellularity. It is important to see, to reinforce this idea that this automating analysis will make you go through every single population, and you are more prone to identify and not overlook any tumor cell population, even though they might be a small cell population. And here again we have this identification in the report of both the B and the T cells and the respective abnormal phenotypes. So for the B cells, they are CD20 positive, they have a higher forward scatter, they are 5 negative, 19 positive, 38 negative, and they are lambda restricted. And for the T cells, we can see the 4 inside scatter is normal, but the CD4 expression is lower compared to the normal CD4 positive T cells. CD5 expression is a little bit reduced as well, and they are 38 negative. And here they recommend a full characterization of both these clones. I can tell you that for the B cell clone, it was a lymphoplasmacytic lymphoma, and moving to the T cell clone, I can show you here that these cells are represented in red, and this is the CD4 cells. This is the CD4 cells. And these CD4 cells are the red cells, the abnormal cells belong to the V beta 13.2 family, and the rest of the normal T cells is represented in here. If we want to compare to the CD8 T cells, we can see there is no similar expansion, and if we take into account the expression of CD3, we can also see that there is a lower expression of the abnormal CD4 positive T cells, and this is very suggestive of one pathology, which is Sézary syndrome. And if we now move into the characterization of the membrane immunophenotype, we can see that these cells in fact express CD28, but they do not express CD26, which is again a very suggestive feature of Sézary syndrome. And looking at two other panty-cell markers like CD7 and CD2, and this is important because in many expansions, reactive expansions, the T cells might lose CD7, but they will maintain the CD2 expression. But in this case, as you can see, they lost the CD7, but the CD2 is decreased, and some of the cells do not express CD2 at all. So this confirmed our suspicion of this Sézary syndrome, along with the clinical features. Of course, it's always important to call your attention to the fact that you have to be very cautious when there are T-cell expansions, and you have to take into account the genetics, the immunophenotype, but very importantly also the clinic of the patient, the signs and the symptoms, which are very important before you suggest this is a leukemia, because before you label the T-cell expansion as a leukemia. So the take-home message from this part of my talk would be this automated cell classification checks for normal versus altered phenotypes and or normal versus altered cell numbers for any cell population. The use of numerical alarms requires prior definition of normal age-related reference ranges. Very few alarms, event rates less than 1%, were associated with normal reactive samples, and in contrast, event rates around 40% were associated with alarms in data files from CLPD-involved specimens. Very important to remind you that successful automation of data analysis in clinical flow cytometry requires the use of standardized antibody panels, instrument calibration, and sample preparation. And this is a key feature, because otherwise you cannot compare your sample against the reference LST database. And another important feature is that if you find less than 5% of alarms for normal cells, this might be used as a criterion to identify successful performance of the whole strategy, and you have an external evaluation inside your sample, because you are comparing your sample, your cells, to the reference database, and that reference was created outside in different centers. And so you can evaluate all your procedure, the pre-analytical and the analytical phase of your procedure. And this is again an added value to use this approach. Now let's do our live demonstration using the database. So I will include the file. I will select it. It's this one. Select. Okay. Then I will fill in the age, which is 70 years old. Pick up the LST, give it OK, and the software will start the analysis. After assigning all the normal populations when compared to the database, it tells me that there are percentage of events in the checked populations is higher than expected. It then reminds me that I have to fill in the absolute numbers, 2,700 leukocytes. And we are now ready to start our check populations. But before we move into that direction, I would like to change the font size of the parameters so that you are able to see all the labels in every axis, namely the lambda and the kappa, for they are very important in this dot plot regarding the B cells, and the 4 and the 8 for the T cells. I would also like to call your attention to this graphic here, the APS. The APS is very, very relevant to separate different clusters, and because it takes into account all the information contained in the tube for every event, so not only the fluorescence parameters but also the scatter parameters. It's sometimes one key tool to separate different dots and to assign them to their clusters. But it's better to see than to describe. So let's start now checking the populations. We start with the unspecified nucleated cells. If you remember correctly, we have the basophils, which have very high 38, and then we have the other gray dots, which are the dendritic cells, and the black dots are the ones that we have to decide upon. So I will accept the first suggestion of the software and we'll call them unspecified nucleated cells. Then I will move on to the neutrophils. And we have a few dots around here which correspond to doublets, and the rest, very many dots, are neutrophils. Then moving to the eosinophils, again we have doublets, but we also have debris. In lymphocytes we start with the B cells, the mature B cells, and the lambda, which I will accept, and the kappa. Now when it comes to the kappa, I have to say that there are two different clusters here. One which overlaps the normal assigned kappa cells, but the other one is completely set apart in the APS. And why is that? If we look at the different dot plots, we can see that, for example, for 19 and 20, their expression is clearly above the expression of the normal kappa cells. And this is a very key feature of one of the chronic lymphoproliferative disorders syndromes, as well as the fact that these cells have higher forward and side scatter. And this is very, very suspicious of hairy cell leukemia. I will take out these few dots that are doublets, and I will assign these cells as abnormal expanded B cells, and we can then move back and confirm this at the end of the analysis. If we now look at the T cells, it first asks us to look into the double negative T cells that are not gamma delta positive, so the gamma delta negative. Very few dots. Here it's the same. The same. And here again we have doublets and we have debris. Debris we'll take away the debris and we accept the cells. And finally, doublets and all these debris. The analysis is finished, but it tells us that we have populations above 20% of the reference. So we have to review, we have to go back into reviewing them. These populations are lymphocytes, they are T cells, and they are double negative or CD8 dim T cells, gamma delta negative. I confirm this is the case. And here you can see we have two different subsets. In fact, we have three different subsets because these very small subsets correspond to the truly double positive CD8, CD4 T cells. And the rest, these two, I will accept as 4 positive, 8 negative, even though this cluster here expresses dim CD8. Now, our analysis is complete, and as I told you previously, we can take away all the nucleated cells and then check the normal B cells and the population we've assigned as the abnormal expanded population, and you can see if you look at the APS, they are completely apart. So 3 different clusters. This cluster is completely apart. Another thing I would like to show you is the fact that this abnormal population is in fact very small. It's only 0.57% of the total of the leukocytes, 15.3 cells per microliter, and 533 events in total. Let's take them out here, and I would like to show you another feature. That's the fact that he classified the plasma cells, circulating plasma cells on its own. As you can see, CD38 is also very useful for not only for the NK cells, but also to identify circulating plasma cells. Okay, now let's move on to our report. And as you can see, the first page of our report describes the frequency and cells per microliter of our sample when compared to the reference. So we have increased number of lymphocytes in this case, and we have monocytopenia as expected. This is another feature of hairy cell leukemia, very few monocytes. And it identifies the percentage and absolute number of the abnormal cells, and also the percentage of debris, which is very reasonable. And on the second page, you can see the complete immunophenotype, which points out the high forward and side scatter, as well as the high CD20 expression, high CD19 expression, negative expression or no expression for CD5, and kappa restricted light chain. We can also see on the bottom line all the populations that were identified in this sample, and as you can see, coming from eosinophils, neutrophils, monocytes, lymphocytes. Then we see there's a problem within one of the lymphocyte subsets, which happens to be the B cells, and here is the T cells separated according to their membrane markers, as we previously seen. Now, before I finish, I would like to acknowledge my team for their commitment, enthusiasm, and sense of humor. They guarantee that we produce good flow cytometry data and diagnosis. Maria Costa, José Pereira, Liliane Luz, and Ana Costa, thank you so much for your support. I would also like to thank Cytognos for giving me this opportunity to share my experience with you by inviting me to present this webinar. Cytognos has supported my lab during several years, namely Karina Cabrita, who is always there for me whenever I have questions, and believe me, I have a lot, and I'm experiencing some new databases or some issues with the software. And last but not least, I would like to thank you all whose faces I cannot see for registering to this webinar and having decided to spend this time, which is always precious, with me. And I truly, truly hope that you've learned something today. And I'm now ready to take your questions. Thank you all so much. It's been an honor and a pleasure to be here with you.